As you have heard, perinatal depression is not a rare phenomenon. It is also a serious condition with lasting potential consequences, is treatable, and is a condition for which there are established and accepted screening measures. Unfortunately, despite the known risks, perinatal depression is generally underdetected by obstetrical and pediatric providers without established screening protocols in place. For all these reasons, in 2015, the American College of Obstetricians and Gynecologists recommended that clinicians screen patients at least once during the perinatal period for depression and anxiety symptoms using a standardized, validated tool. The American College of Pediatricians also recommends screening for perinatal depression during routine well-child visits, and the U.S. Preventive Services Task Force recommends screening for depression in the general adult population, including pregnant and postpartum women. The most widely utilized screening tool for perinatal depression is the Edinburgh Postnatal Depression Scale, or the EPDS. The EPDS is a brief self-report measure that takes less than 5 minutes to complete. It has a high specificity and sensitivity for perinatal depression, has been translated into 12 different languages, and has been validated in both the antepartum and postpartum populations. It includes anxiety symptoms, which are a prominent feature for most women with perinatal depression, and excludes somatic symptoms such as decreased energy or change in appetite, which are common in many non-depressed perinatal women. The last item on the EPDS addresses thoughts of self-harm or suicide. As with any screening tool, it is important to understand that a positive screening result on the EPDS is not in itself a diagnosis of depression and must be followed up with a clinical evaluation. Misuse of the EPDS as a diagnostic tool can lead to potential harm by leading the clinician to either undervalue a patient's report of depressive symptoms or to misdiagnose a patient who actually does not meet the criteria for a major depressive episode. In fact, studies on the EPDS show that nearly all false positive screening results are patients who screened positive but did not have a diagnosis of depression on further evaluation did indeed have a diagnosable mental health condition. While universal screening using the EPDS or other measures during and after pregnancy can increase the detection of perinatal depression, it is also important to acknowledge that detection alone is not the goal. If detection does not lead to treatment and a reduction of suffering, it is of limited value. It is important that primary care offices go beyond screening by developing evaluation and targeted referral processes for women who screen positive. But even when that is provided, we must consider barriers to treatment that many perinatal women face, from logistical ones such as transportation and childcare to the stigma that is associated with mental health treatment. Integrated care models, where mental health is integrated into an obstetrical or primary care setting, is a model that addresses many of these barriers and have shown success in improving both engagement in mental health care and the depression treatment effect for perinatal women. Once a woman is identified and presents for psychiatric evaluation, the astute psychiatrist must be aware of several diagnostic considerations. The DSM-5 defines a major depressive episode to be a 2-week period in which at least 5 of 9 diagnostic criteria are present, one of which must be either depressed moods or loss of pleasure or interest. In the context of perinatal depression, it is important to note that many of these criteria, such as changes in appetite or sleep, loss of energy or diminished concentration, are actually expected and normal symptoms of pregnancy. Therefore, it is necessary to place these criteria into a broader clinical context. Furthermore, it is important to take a careful history to determine the onset of presenting symptoms. If the current or more recent major depressive episode begins either during pregnancy or in the 4 weeks following delivery, the specifier with peripartum onset can be added to the diagnosis of major depressive disorder. Depression, which begins more than 4 weeks postpartum, cannot be formally diagnosed using this specifier, but of course can still cause harm and requires treatment. An evaluation of a perinatal woman for depressive symptoms must also include a careful consideration of differential diagnoses. Approximately 85% of postpartum women experience a set of symptoms called the baby blues that peak between 2 to 5 days postpartum and generally resolve within 2 weeks. A woman with the baby blues may feel weepy, have mild mood lability, irritability, or anxiety. However, these symptoms do not impair function. While the baby blues can be considered a normative experience, women who have the baby blues are at an increased risk for postpartum depression, and so their symptoms should be followed over time. As bipolar disorder can also present as major depressive episode, it is important to inquire about previous manic episodes, a family history of bipolar disorder, and any personal history of adverse reactions to antidepressants. Anxiety and obsessive-compulsive symptoms are commonly co-occurring complaints in perinatal depression, and so the clinician should thoroughly explore these domains in the review of symptoms. Finally, postpartum psychosis is a rare condition that is most commonly associated with bipolar disorder. All perinatal women presenting to a psychiatrist should be asked about any experience with auditory or visual hallucinations or unusual or paranoid thoughts. Finally, when exploring the domains of suicidality and homicidality, it is important to inquire about any thoughts of harming the fetus or infant. Importantly, postpartum intrusive thoughts of accidental harm to the infant are nearly universal, and approximately half of postpartum women may experience unwanted thoughts of intentional harm to an infant. Thus, when these types of thoughts are revealed by a patient, it is important to explore them further in order to gather a more complete understanding of the patient's experience. For example, one might inquire about the frequency and intensity of these thoughts, absence or presence of intention to follow through on the thoughts, and the evaluation of whether the thoughts are egosyntonic or dystonic, and whether or not they have a psychotic origin. Finally, as in the general population, it is important to consider substance use disorders, general medical conditions that may present with psychiatric symptoms, and organic brain disorders. Measurements of hemoglobin and thyroid-stimulating hormone levels are generally recommended, and imaging should be done if there are any other symptoms present that may indicate a primary neurological cause.